As you all are finishing getting your lunch, and it looks like there may be enough for seconds if you want to get up and get them quietly while our program is going on. Want to welcome you again to this last presentation in the 2012 National Primary Care Week main event. We may have one more event coming in a little later in the year, but we will let you know about that. It's been our pleasure as AHEC to kind of facilitate this process, and certainly as the Aging Studies program, it's our total pleasure to present and support this program with Dr. Lovy and his expertise in psychiatry and work with aging patients. So with that, I'm going to turn it over to George Cho to do the introduction and tell a little bit about his club.
Yeah. Hi everyone, I'm George. I'm from the Neuropsych Club, and it's my pleasure to introduce Dr. Lovy to you guys. You guys may know him from OMM because he's really active there, and we've all had a lot of fun with him. But Dr. Lovy, he graduated from the Chicago College of Osteopathic Medicine, and he's board certified in psychiatry. He's been managing 13 long-term care facilities, so that's a lot. And at the same time, he does a lot of sports medicine, so he's been really active recently. Yeah, and that's Dr. Lovy. Sorry, this was really last moment, but enjoy.
Okay. Okay, well, first of all, I'm very honored to be here, and I'm glad there's a nice turnout. It's not on your evaluation sheet, but I want you to tell the truth. How many of you are here because of the food, and how many are here because of the incredible brilliance of the lecturer? And you can be honest. Don't put your name on the chart. Okay, I've got literally an hour and 20-minute talk, which I'm going to try to do in 47 minutes and 38 seconds. So I'm going to forget all of the jokes. But I think one of the important things is when I started to research the topic, there were only 5 articles. And 3 of the articles said there's not enough research on it. So most of this is kind of new. And we picked this title, and you'll see why as we go on. Background, PTSD's been around for thousands of years. If you read the Bible, Saul had it. If you're into history, Alexander the Great had it. He had nightmares of all of the people that he beheaded every night. So this isn't anything new. It's been called different names, but it is a real phenomena. It is not, as some people say, a psychiatric diagnosis made up by psychiatrists to get paid. It really does exist, but it's been called many different names. Shell shock, DeCosta syndrome, that was back in 1918. So it's a very, very real phenomena. Women are as prone as men. So this is not a war psychiatric issue. People who've been in combat get it, but people who have never been in combat get it. And we're going to go a little bit more into that too. 80% of the veterans in the Korean War suffer from a variant of PTSD. Now, this is something new. I didn't know this. You know, I did a lot of research on this topic. That a lot of them, even now, what is this, 40 years later, they have nightmares of their feet falling off and problems. Because frostbite, actually, if you read the statistics about Korea, frostbite took out more American soldiers than the enemy did. So it's kind of important. So it's not a military phenomena. It's a brain-mind phenomena. Now, between 1995 and 2000, there were 2,200 suicides in long-term care facilities. And you have to wonder how many were due to PTSD. So why would somebody 70, 80, 90, 95 years old commit suicide? One of the theories is that's maybe the last thing they have control of. They realize in this nursing home, they're going to be fed, whether they like it or not. They're going to be bathed, whether they like it or not. They're losing. Aging really is an issue of loss. Loss of esteem, loss of function, loss of structure, loss of friends, loss of relationships, loss. The last thing is, I'm going to pick the time when I'm going to die. So it is a very serious thing. And as a matter of fact, if you want to look at the real statistics, what age group has the greatest suicide rate? 45 to 70-year-old white males, not the kids, okay? Now, we have baby boomers. They're coming into the nursing homes now. So the phenomena is going to be there for a long time. In the DSM-4, which is technically speaking the psychiatric Bible, it's an anxiety disorder. Anxiety is a major, major component. It's the most common mental disorder in the elderly. Anxiety. They're anxious because of loss. They're anxious because of medical conditions. They're anxious because they're losing things. They're also anxious because portions of their brain is no longer functioning as well as it did. And one of the hallmarks of vascular dementia is I'm losing it, and I know I'm losing it, and it ticks me off, which is very different than Alzheimer's. With Alzheimer's, they don't know that they're losing it because they don't know what they don't have because they don't know they ever had it. That really does make sense, but I'm not going to say it again because I get lost. But vascular dementias, that's one of the problems. And people with PTSD usually have vascular dementia. It's not that you can't have both. It accounts for 16% of the mental health bill, anxiety. And the treatment is not, I tell you what, 1 milligram of Ativan QID times 27 years. And that's what we see sometimes in the nursing home. It involves treating the anxiety. It involves understanding what's making the person anxious and working within the framework and then cutting back on the anxiolytics. As a matter of fact, there's a lot of research now basically saying that if you're using Ativan, Librium, Valium, Xanax, in the elderly, 27% chance of them having a cardiovascular incident, much more so than the black box warning about antipsychotics. So when I do the nursing homes, I cut back on the anxiolytics to a safe number. Now, what triggers PTSD? Unexpected death, illness, injury, life-threatening. But I will tell you, you can have PTSD by proxy. I gave a PTSD lecture about 6 months ago to a bunch of doctors. One doctor was a psychiatrist. He came up to me. He was in the military, a lieutenant colonel, psychiatrist. He had never seen combat. His job was to talk to people who are leaving the military and help them reacclimate to civilian life. He heard so many horror stories from these kids coming out. He actually, honestly, has PTSD. He has nightmares by proxy, nightmares due to what he was exposed to. Okay? Another interesting statistic. People with PTSD are twice as likely to develop Alzheimer's. So Alzheimer's is not just a single entity. It can be influenced by circumstances. It can be influenced by lapses in the way the brain functions. And we're going to go over that. The hypothalamus is the most implicated. You know, when I was in medical school, I was taught the hypothalamus is actually controls the four F's: feeding, flight, fight, and propagation of the species. But it actually goes far deeper than that. Okay, most frequent, insomnia. But we're not talking, I can't sleep once in a while. We're talking night after night after night after night, and these people are given all sorts of medications for sleep, and they still can't sleep because we haven't addressed the problem. We've only addressed the symptom. Elderly combat veterans should be monitored for changes when a significant stress event occurs. I'm minding my own business. I'm taking students to a nursing home. I'm watching TV, and it looks like a show. Airplanes are flying into this tower. Well, it was 911. We went about our business. For the next 4 days, my phone rang off the hook from veterans who knew they had no issues, no problems, never had a day of PTSD in their life since 911. They were crawling out of the woodwork with PTSD, and we're going to go over why that happens. Retirement can exacerbate it. When you're working, you're working. You're at the top of your game, or somewhere in the middle of it anyway. You're useful. When you stop being useful, you start reminiscing about all of the things that you did wrong in your life. And some of them can trigger these PTSD symptoms. It's associated with higher rates of mortality from suicide, health complications, higher health costs. In other words, PTSD is not an innocuous, get over it. Just quit that. It's no problem. It's a major, major issue. It's a major, major problem. I had one patient in the nursing home, and I will tell this as rapidly as I can because I got to get on with my talk here. So in the nursing home, totally demented. He knew his name but couldn't remember anything else. But he did remember his military number, 07732-984. But he always wore this hat with a submarine on it. Skip up 6 months. We got pictures of submarines, and it turns out he started to talk to me. He was never in a submarine during his military career. He was in a submarine tender. You know what they do? They're the ones that take the submarines and resupply them. And he heard the stories from all of these men about, because I don't know if you know this, but 30% of the submarines in World War II never made it back. We lost 30%, the Germans lost 42%, okay? And this bothered him. 911 occurred. I was there, about 3 weeks later. And he comes up to me and he says, Dr. Lovy, I'm scared. You think they're going to call me back? That's what he's been worried about for 45 years, that he was going to be called back in the Army. And I just, rose up to my full 5 foot 682 pounds, and I said, absolutely not. I'll vouch for you. You served your service. You're fine. That was the end of it. He still had dementia, but it was 1/2 of what it was before. And he died in peace, and he needed half the medication that he was using before. So the PTSD component was major in the diagnosis and the treatment of this gentleman. It can be repressed for a long time, I have PTSD, I have a variant of it. I'm usually okay. You make a loud noise, I'm going to want to get under the table and yell incoming. But just for an instant. And then I realize that I'm here and this is fairly safe. I mean, I'm in Kirksville. What can happen in Kirksville? But don't answer that. Okay. So the DSM-4-TR is the criteria. Whatever else is said, the criteria are these: an exposure to the trauma, the event is re-experienced, avoidance, arousal, it lasts for over a month, and your life is disrupted. You've been exposed to a traumatic event. Now, what's a traumatic event? If it overloads your system. For many people, seeing blood, seeing an accident is a traumatic incident. I have a medic who used to help me with some of these lectures. For him, blood was a nuisance. He had to stop the bleeder, get rid of the blood so he could tie off the blood vessel. So for him, blood was a call to action. For most people, it can be traumatic. So the trauma has to be evaluated on the basis of what is in that individual's normal life. There's a threat, a physical threat. I still have PTSD from an incident that occurred when I was 6 years old. A really, really big guy of 9 threatened to kill me at recess. I still remember that. Okay? Now, response involves intense fear, helplessness, or horror. The helplessness is very important. You can't do anything about it. You don't think you can do something about it. You're convinced you can't do anything about it, and you're also convinced that what you did was wrong. So part of the therapy now involves correcting those issues. True trauma, where you feel powerless. I couldn't do it. I could see it happen in front of me, and there wasn't a thing I could do. It was like in slow motion, or it was like in rapid motion. I should have been able to react, but I could not. And then the I could not turns to I would not, turns to I did not, turns to I should be punished because I did not. And then that comes back and reproduces itself over and over again in your life. Magnitude of horror that they would overtax any normal human being. What does that mean? That means for each individual you have your breaking point. And it's important when you're in the nursing homes or when you're about your general practice to know what the breaking point is for that person and to keep that threshold as low as possible. The fundamental dynamic is re-experiencing the trauma. Now, this is not recalling. When I ask the question, what do you remember? Well, I remember that time when. That's not PTSD. They don't remember. It is locked in the brain. What happens? The locus coeruleus and the nucleus accumbens work together. One recalls, the other puts it in time. They break apart. So now you have the symptoms and you don't know where they're coming from. You have an issue, you have a smell, you have a sound. And it triggers a response and you don't know where that response is coming from. So it's at an unconscious level. But you try to bury it. You don't want anything that resembles the original trauma to occur. So if it occurred in the rain, you eventually want to avoid rain. Then you want to avoid going outdoors. Then you want to avoid people who talk about rain. Eventually you end up isolated. And what's one of the most common things that happen in a nursing home? These people are isolated. They're alone. The only people that really care, sometimes a family member comes and visits. Occasionally there's 1 to 5 nurses that come, and unfortunately I'm the highlight of their day. You know, I come and I show up and I talk to them like they're actual people. Gosh, that's a novel concept, isn't it? Persistent avoidance. They avoid like the plague. One last story, and then I'll get on with it. I had a patient that could not stand the smell of diapers. And he had a problem with his grandkids because he would babysit and he'd have to change the diapers. Spin forward about 6 months, we're working on it. He was in the Pacific during World War II. Do any of you know what a Canberra is? It's a twin-engined British airplane, okay? It landed. The engine broke off, turned around and came through the cockpit and roasted everybody. Killed them all, fried them. His job was to pick up the pieces, put them in bags for later identification. The smell of burning flesh and diesel fuel for him was so similar to the smell of a dirty diaper. So he had no knowledge that this was what was going on, but he had these flashbacks. Once he discovered it, he still was uncomfortable, but he could at least change the diapers on his kid. Hyperarousal. Anything out of the ordinary really kicks off your triggers. In the nursing home, everything is calm. The next patient next to him starts to yell. All of a sudden, they're back in the South Pacific, or they're back at home where they were abused, or. And if we're not sensitive to these clues, we're going to miss them entirely. So, fight or flight. We don't always have that choice. It's really fight, flight, or freeze. If you look at small animals, when they're about ready to get killed, sometimes they just freeze. They've accepted it. Sometimes freezing makes the aggressor lose interest and they go away. So it is flight, fight, or freeze. A lot of these people will freeze. They're not going to talk about it. They're not going to do anything. They're going to just sit there. I'm having a conversation with a patient. Everything is wonderful. And I say something which is totally innocuous, I think. And the patient turns away and will not talk to me again for that session. I've triggered something. They freeze. Duration. Got to be 3 months. You're not going to see anybody in the nursing home that had their trauma occur 3 months ago. It happens 3 years ago, 30 years ago, 50 years ago. And because it happened 50 years ago, that don't mean it goes away. That's one of the important points. If you don't address the PTSD, it does not go away by itself. It stays there and festers literally until that person dies. So the duration, but it has to be over 3 months. Now, can it happen? We've had some. They're doing fine. Then all of a sudden, on 1 week, mom dies or a son dies. A daughter gets in an automobile accident and is gone, and a very significant other stops visiting. Now, all of a sudden, that only happened 2 months ago, but it's a reminder of something that happened 20 years ago about abandonment. And that person now actually can be diagnosed as having PTSD, impaired functioning. I have known many people who at one time or another were at the top of their game. They had IQs of 120. Now their IQ is only 90 because they've had a TBI, a traumatic brain injury. 90 is wonderful. Not if you got 120. If a physician gets it and he's got an IQ of 170, he's down to 160, he knows it. He knows there's something wrong. And he's trying to find out what went wrong and how and where and when. So there is an impaired functioning. In a nursing home, what happens? I had a farm, I had a wife, I had kids, I had 2 cars, and I had 3 tractors. Now I'm in a nursing home. I got a roommate who snores. I got nurses who wake me up to give me my sleeping pill. Come on. I'm nowhere near what I used to be. Of course that's going to cause depression, but it's also going to cause a recurrence of any PTSD elements that might have existed in that individual before. Who gets PTSD? Anybody can, anyone's vulnerable. I just made this list up of the things that are responsible for almost any action. There is a genetic component. We're discovering with PTSD, some people are more genetically prone to PTSD than others. That doesn't mean you're doomed to get it, but that means you're more likely to get it under similar circumstances where someone else won't get it. The brain's plasticity. The earlier you get it, the more likely it is you can compensate. The later you get it past 3, it's going to probably stay with you. It's a chemical matrix. If I were to tell you from the day you were born until you're 7, you're no good, you never will be, you're always a piece of garbage, and, that's going to change your chemistries, and it may change it for life. You're going to not be able to achieve for the rest of your life because you're always going to believe what I told you. Not because you believe it, but because it's already changed your chemical matrix. We can make these chemical changes in brains. Formative tutorials. I've been told since I was a kid, I'm going to be a success. So if I'm a failure, no, I'm still a success. Get the opposite. I've always been told by my parents, I'm a failure. I'm never going to amount to much. That's going to stick. That's going to stick. I'm always going to be trying to prove my worth. And sometimes you can't prove the unprovable to the people who don't want to have it proved. Put this in the nursing home. They're nowhere near where they were intellectually, emotionally, neurochemically, physically, or psychologically. Of course, they're going to feel somewhat saddened about their loss. And this may trigger a time in the past when that happened, and now that time in the past, it's like it happened yesterday. Individual experiences, time, duration, frequency, intensity. Sometimes one event, why is it some kids can put their hand on a hot stove, withdraw it, and they never do that again? And why is it some kids, they keep checking it out? Well, we have a different genetic predisposition. I don't know if there's a specific brain area called the stubborn area, but I'm convinced it exists. Some people are more stubborn than others, and that's okay. All right? All traumatic experiences are stressful, but not all stress is traumatic. When I was overseas, I heard the choppers and I heard the call for a doctor. That was stressful as hell. I could be shot down, I could be killed, and my life would end right then and there. And you know what I thought about? What's the lesion? Is it an entry wound or an exit wound? How can I talk to? I wasn't concerned about that. So it was stressful, but it wasn't traumatic. Now, if I would have faced a situation where I should have been able to fix it and I didn't, that is real stressful. I used to tell people I was the biggest coward that ever lived. I was afraid to face the guys a year later if I didn't do the job well then. I'd rather die doing my job than not do my job. So the job wasn't stressful. It was the sequela of the job that could have been stressful. Now, understanding triggers. This is one of the more important slides, and what I put in red, how many of you are DO students? Those are the ones that you're going to find in patients, and they're not going to tell you about PTSD, but those are the triggers. A visual, they're going to see something, a sound. I took a leave in Hawaii. A car backfired. You could tell who was stationed in Hawaii and who was there on leave. The one stationed in Hawaii said, car backfired. The rest of us were under tables yelling incoming. Okay? Sound, smell. How many of you seen that picture? You know, the smell of napalm in the morning? Certain smells triggered, like my guy who couldn't do the diapers. Certain tastes. If you want to take the time, talk to some Vietnam veterans and ask them about the Monday pill. It tastes like metal. They hate anything that tastes like metal in their mouth because it reminds them of their tour and all of the bad things that happened during their tour. Physical. We have physical issues. We have physical problems that are not due specifically to a physical lesion. They're due to a mental condition that is causing the physical lesion. I'm going to ask you, how are things with your dad? Oh, fine. Well, what am I going to believe? What you just told me or what your body just did? It happens in the nursing home, but even more so because their defenses are lower. The hypothalamus is not working at its top. And when it's not working at its top, it's going to let things through that otherwise would have been blocked. Understanding triggers. Significant dates. There's a fund of literature that says they don't count. I don't agree. But the significant date may not be the date that the individual lost their significant other. It may be the date that they found out that they had cancer. It may be, like for my unit, February 19th, big ambush, 27 guys died. We go to the wall every year. Very significant date. And some guys decompensate on the 15th, 16th, 17th and pull it back together on the 21st until the next year. Because they reminisce about what they could have, should have done. Stressful events, strong emotions. A lot of people with PTSD will appear bland. I wonder how many people were diagnosed with schizophrenia because they were bland. Schizophrenics frequently do not have object relations. You're part of the furniture. You may be a good piece of furniture or a bad piece of furniture, but they have no relationship with you. These people want to shut down emotions because any emotion can trigger this PTSD thing. Any combination thereof can cause an exacerbation. Associated features. I don't know what happened, but there's absolutely no doubt in my mind, Doc, that it was my fault. Absolutely no doubt. Because that comes from their previous training. So when you hear that, I'm not saying it's PTSD, I'm saying don't rule PTSD out. The only thing I'm trying to impress on you is to consider the possibility. If you never consider the possibility, you can't possibly find it. If you consider the possibility, then put the other thing in your mind. If you have a good hammer, not everything is a nail. But just be aware that it can happen. Addictions. For many people with PTSD, there's a simple solution for addiction, for PTSD, for bad things. Librium, Valium, Xanax, Southern Comfort, wine, whiskey, marijuana. It masks the symptoms. So now we have two problems, the original problem which was not solved and the addictive problem which now becomes a separate problem. And they both have to be treated. Somatic complaints. I'll share one experience with you. I've had a chronic hip pain for maybe 15 years. I've had the best OM people on the planet work on it. I go to the OM meetings, I go to the academy meetings. They all do wonders. While I'm in Chicago, one guy, let's play. So I showed him what I did, and he said, all right, I'm going to show you what I do. Get into a comfortable position. What the heck does that mean? So I'm wiggling around, I got into this position, and I had a flashback. That's the exact position I was in when I got shot out of a helicopter. For the next 45 minutes, I was back in Vietnam. I could hear the sounds. I could smell the smells. My eardrums were ruptured. I was re-experiencing it at the same time that I was in the OM lab. And that lasted for about an hour, hour and a half. Somatic complaints. Once we uncovered that, I haven't had that pain since. I've had many others, but not that one. That one's gone. Overcompensation. I'm going to keep doing this till I get it right. So it's amazing how many of these people have what we can clinically call OCD. They don't have OCD. They're trying to get it right, finally. And they never can. Because the problem has not been addressed, only a symptom. Message for the medical students, it's wonderful to treat symptoms as long as you understand you're treating the symptom so you can get at the problem. But if you think you've treated the person because you've treated the symptom, you probably are not doing yourself or that patient justice. Death anxiety. It's amazing how many of these people want to die, but they're afraid of death. It's a commonality. I'm the only survivor, and I wish I'd have died with the group. Well, here's the medicine. Yeah, but will that kill me? What? There's that ambivalence. They want to choose the time and the place. Intrusive symptoms or re-experiencing the trauma, this is one of the keys. And you have to dig for it, and sometimes the best way to dig for it is to just let it happen. What just happened? Well, you twist your left shoulder. Oh, I didn't know that. Well, pay attention to that. And then it grows and it grows and it grows. You seldom can treat PTSD on one shot. You know, you're coming to me. I clearly am the greatest psychiatrist that ever lived. Just ask me and I'll tell you. And I have all these diplomas and all that. Trust me, I'm a doctor. That's not going to work. You have to build your credentials and your credibility. Isn't that wonderful in a nursing home? These nurses, they live with these patients. And it's amazing the wonderful insights some of these nurses have on what really makes the person tick. I show up and I do 15 minutes and I'm incredibly brilliant in my 15 minutes of diagnosis and treatment. And here's what I'm going to do. And the nurse says, I don't think that's going to work, doctor, because she knows something that I could not have uncovered. So I use the nurses. I use the staff. Why don't you try this? Why don't you push this? Why don't you get a few more pictures of red poppies? Because I think that's a trigger. Okay? Or don't use red poppies because that's a trigger, depending on where we are and which stage of our therapeutic development. They will avoid. They'll avoid any and every possible interaction that can re-trigger. PTSD is painful. It hurts. They're going to do anything they can to avoid it. Now, frequent symptom patterns, hypervigilance, reactivity, anger or rage. Do you ever get angry and you have no idea why you got angry? That's different than road rage, where somebody cuts you off and you wish you had your twin .50 caliber submachine guns and you'd like to blow them off the road, but you know that's illegal in Missouri. I'm not sure about California, but it is illegal in Missouri. I don't know why I was so angry. That may be a cue, that may be a clue, and it may be nothing, but you have to pursue it. What symptom can a patient have that you as physicians or you as nurses consider unimportant? And if you say one, I think you should repeat the year. There isn't a thing that the patient tells you that may not have significance, because of all the 10 million things they could say, why did they say that? There's a reason. They may not even know the reason. But there's where you have to dig. There's where you have to dig. Depression, shame. Most, not a lot, not all, most people with PTSD are into a lot of self-recrimination. Shame, lowered self-esteem. You know, the reason you got raped was your skirts were too short, and no, that's not the reason you got raped. You got raped because that son of a bitch raped you. You know, it's got nothing to do with it. I had one soldier, totally guilty. He had malaria. I sent him to the rear. He got treated. He came back. His entire unit was wiped out. They went on a patrol. Whole unit was wiped out. His sergeant said, had you been there, they would still be alive because you were our point man. Therefore, it is your fault. Now talk about trauma, huh? So for 45 years, it's been his fault, and he has nightmares, and he would like to join his colleagues. Okay? That's the value of PTSD. In a nursing home, that occurs too. Pay attention to the symptomatology. Negative beliefs about oneself. World War II vets fought the good fight. They fought a good war. They stood up for freedom, justice, and the American way. No problem. Comes 911. Uh-oh. We didn't finish the job. We didn't finish the job turns into we didn't do the job. We didn't do the job turns to I did it wrong, which then turns to PTSD. So that's why they were coming into my office. It's been festering there for 40 years, but they didn't have to deal with it. And who do you treat? You don't treat everyone because you think they have PTSD. And we're going to get into the treatment. Symptoms, this is who you treat. They cause suffering. They interfere with the capacity to work, enjoy life, and connect to others. Those are the criteria. They're causing physical illness. I have a patient with several physical complaints. Remember that, was it second or third slide? All of the physical things that are concomitant with PTSD. Gone to the best neurologist, the best psychiatrist, the best cardiologist. There is pathology, but we can't find the reason. Well, you might take a look at a subcortical reason and a reason locked into their unconscious. Something's wrong. They don't lessen within 1 to 3 months. Suicidal thoughts. I ask this question every time. Do you really want to die, or do you want to stop living this way? Because if you want to stop living this way, let's work on it. Let's see what we can do. Let me buy you 6 months. I can do this at the nursing home too. I love this 98-year-old woman. She's the youngest. All brothers are dead. All sisters are dead. All uncles, aunts, cousins, neighbors, and friends. What am I living for? Well, for a bingo tomorrow. What the heck, you know? Life is still worthwhile. And I use a tactic, which I don't recommend, but, you know, got to try it out. I tell some of these people, you know, it's entirely possible the best thing you've ever done in your life is what you're going to do tomorrow. But you got to be around for it. Huh, I never thought of it that way. Well, just think about it, you know. And in the meantime, let's get you something to do that isn't demeaning. You know, if it's counting bed sheets or it's helping pass out plates in the cafeteria, something that you feel that is useful. It's amazing how much that helps PTSD. It's a myth that it'll go away. Just stop it. Just quit thinking about it. Well, it's like telling you, stop being you. Show me how. Well, I can't because it can't be done. PTSD is pervasive. It's important. Now, the role of pharmacotherapy, for those of you nurses I know are interested because a lot of their doctors use them, and it's got to be directed at the core. If there is a PTSD symptom with psychosis, you treat the psychosis. You are not treating the PTSD. You're treating the psychosis so you can get to the PTSD. If I break an arm, you give me an anesthetic, you're not treating my arm. You're giving me an anesthetic so you can treat my arm. So keep in mind, treating symptoms are fine, but you're not treating the problem. Primary targets, can't sleep. Can't sleep, can't sleep. Sleep problems are one of the cardinal signs of depression, so we always look for depression. They're also a cardinal sign of anxiety. Why can't I sleep? I am so worried about 4,000 things. How can I possibly get to sleep with all of these problems? And the use of anxiolytics does not help. They're still anxious, but they're not able to express it. That's the main thing with anxiolytics. Exaggerated startle response. I'm not going to do this today. Wrong audience. But I've done this at VA hospitals, and I'll make a sudden move, and I can tell exactly who's got PTSD by the startle reaction of the people. That's one that really, really hard to fake, the startle reaction. And unfortunately, Bridget's done that to me just once or twice in my career, and I damn near jumped off the table. And I don't have PTSD, all right? Okay, that's another one, denial. Irritability or outbursts of anger, can't concentrate. I have a task to do. Halfway through the task, the self-doubts come in. I can't do this. I can't do this right. People expect too much of me. I give up. These are cardinal signs. Antidepressants. Not just any antidepressant. The VA used Wellbutrin for years. It's dopaminergic. The major deficit in anxiety, depression, major trauma, cardiovascular trauma, automobile accidents, is a flush of serotonin. They lose serotonin. So you got to replace the serotonin. And I used to replace the serotonin, and I would tell the patient and the family, this isn't for your depression. You don't have depression. I agree with you. This is to replace the serotonin that your system lost, and it does make a difference. They should be regarded as the first line of pharmacologic agents, not anxiolytics. You give a person with PTSD an anxiolytic, it's going to slow them down until the rage boils up. I wonder how many of these mass murders that we see, and of course I don't have any insight into this at all. I have references, you know, they've seen psychiatrists and all that. Many of them were on massive doses of Ativan or Xanax instead of an antipsychotic or an antidepressant, which would have treated the problem, not the symptom. Doc, I'm anxious, just give me, what is it, 1 milligram of Xanax TID times 27 years. And that's about the way they feel. The preferred first line of defense, and I'm pushing the wrong button. Now, when there's a psychosis, which can and does occur, then an antipsychotic is useful. It's useful short term. You put somebody on an antipsychotic, they don't need that antipsychotic for 6 to 8 years. They need it for 6 to 8 days. And then you take them off of it and see what happens. And in the meantime, you're going to be able to effectively treat them. So severe hyperarousal, psychotic phenomena. I average 1 phone call a month. And this is 45 years ago. A wife calls, says, my husband's in the bathroom, he's shooting VC. Yeah, put him on the phone. Yeah, you know who I am? Yeah, you're Dr. Lovy. Okay. No VC, put the gun down, throw it out the door. Do you trust me? Yeah, well, and do that. Okay. But now we got to get him to the hospital because this was a psychotic episode. These people divorce multiple times. Why? They love their wives. They're afraid of them. They're afraid they're going to kill them. They're afraid they're going to hurt them. Go to the nursing home. They're afraid of object relations. They're not schizophrenic. They're afraid to get close to anyone because if you get too close to somebody, they're going to die. You can't handle the responsibility. They're going to die. So the hyperarousal symptoms, psychotic symptoms, short-term. Prazosin, wonderful medication. Medical students, you know what the other name of that is? Minipress. It's used for blood pressure. Okay? 5, 10, 15 milligrams, wonderful for blood pressure. 1, 2, 3 milligrams, because of its lipophilic tendencies, it helps modulate the nightmares. They stop having nightmares. If you can put a wedge between them and their symptoms and they stop the nightmares, treatment becomes much more effective. Now I have some people, they've had nightmares all their life. I put them on 2 milligrams of prazosin, they don't have nightmares. Now the real symptoms come out that the nightmares were masking. So it's an effective drug for many. 5 associated symptoms: guilt, gaps in awareness, derealization. These are very good defense mechanisms, but when overused, they become part of the problem. Anything, if overused, can become part of the problem. Necessary to address comorbidities, notably substance abuse. I used to go to these reunions, and the amount of drinking is massive. And I'm one of the few that is officially allowed to not drink, because I tell them, if I drink and one of you has a problem, I don't know what I'm sowing to what. So you don't want me drunk. But the drinking is not your solution. Your solution is to address the problem and not have a dual diagnosis. Drawbacks of the medication: weight gain, diabetes, tardive dyskinesia. Now we've had people on low doses of Haldol and they have tardive dyskinesia for the next 20 years. And we've had others on high doses and they don't get it, but it is a risk factor. Diabetes is a definite risk factor because of what it does internally to all the systems. What are one of the core problems with people who eventually develop diabetes? Chronic strain. The whole world is against them, and they're struggling, and they're struggling, and they're struggling. And then all of a sudden, one day, 110, 110, 110, 170, 190, 300. Now we have a true diabetic. It's changed the islets permanently. They're diabetic forever now. But that can be treated. Healing, you manage the symptoms, you occur when the traumatic memory happens. For the nursing staff here, so when one of your patients in the nursing home comes up with an untoward response, why is it this person has no issues except with this one damn nursing aide? Well, let's see, maybe that nursing aide reminds him or her of. So you have to be sensitive to it. You have to look at it as a possibility, not a probability, but just a possibility. It occurs in a climate of safety. You cannot do PTSD work in a climate of fear because you're just reproducing the symptoms. Some of these older people, you can't take them back physically, but you can take them back in memories, but they've got to feel safe. Your DOs, you put your hand on them. That's pretty safe. That's pretty safe. Look, I'm here to help you. I'm not going to let bad things happen to you. Now, you don't do this on day 1. You may do this on day 400 when they finally get to trust you. But it's very important to make that contact. Otherwise, you become part of the problem. You're not part of the solution. And then it only occurs when the boundaries are intact. I know who I am. The nurse knows that's the nurse. The aide knows that's the aide. They're not part of the patient's family. They're not there to cater to the patient. They're there to help the patient. Kind awareness. Yeah, I know doesn't do it, because what do you know? You don't know what they're going through. When confront. Now, there comes this magical moment, and Freud talked about this in his psychoanalytic, where you stop talking, you start doing. So when are we going to start doing? We've talked about it, we've thought about it, we've gone back into your childhood. Now we're going to have to make some changes. The changes are scary, but I would not allow you to do those changes if I did not think that they would be helpful. And I wait until that right moment. So it occurs when you confront. For some of the women that we have in this community that have PTSD due to a rape and other untoward events that occurred in their life, there comes this magical moment where, no, I'm okay. What happened was bad. I'm okay. The person who did it to me was bad. So they're the ones who are the guilty, not me. And then I always, if it's a young lady, I bring up Fran Drescher. She's a wonderful example because she was brutalized. She's overcome this very nicely. And she even talks about it and has written a book about it. So it's nice to know, and it's nice for the patients to know you're not alone. So even in the nursing homes, it's amazing how many of them will congregate. As demented as we think they are, they congregate together because they are sharing pretty much the same cognitive mindset. So, got to be over 3 months. If it's less than 3 months, it's called adjustment disorder. If it's more than 3 months, consider PTSD as part of your differential diagnosis along with major depression or bipolar. Suicidal thoughts occur out of the blue. Never was suicidal before. Now, the one thing to toss in here is, first of all, check the urine. Because the most common cause of an acute psychotic episode in a nursing home patient is a UTI. It is not a psychiatric problem. And you address the UTI, the psychiatric problem goes away. So I want to see the UA. But then, if it persists, then I will reach for the antipsychotic. And if the patient is taking any medications for their symptoms, then we want to know, are their symptoms under control and we can get to the problem now, or the problem is solved because you're not even thinking about it because of the medication that you're on that is masking the problem. So it's a myth that it'll go away. Just forget about it. It happened 30 years ago. What the hell are you doing? If that worked, my job would last 1 day per nursing home. You got a problem? Stop it. And this is what I like to see. Friendship, relationships, hand in hand. And I think that bell tells me that I'm done. I'm out of here. Thank you. If there are any questions, I'll be glad to answer them a little bit later.
And we...
Oh, yeah. One thing. For any of the students here, there's a kind of a summary of these here if you want it. So all of the PowerPoints and all that are in narrative form here. So you're welcome to it.
And we'd like to say thank you very much.
Well, thank you.
I'll put these out where the students...
Oh, great. That's important.
Thank all of you. We have a meeting of our agency...
Oh, I need to have my food.
after this lecture.
Oh, fantastic. Thank you.
You who are in that group...
Yes, I don't need to.
Thank you all very much. Appreciate it. Let's thank Dr. Lovy.